Good afternoon, everyone, and welcome to the Foundation for Opioid Response Efforts webinar. This afternoon, focusing on aspects of Medicaid policies and strategies that can improve access to medications for opioid use disorder in primary care. I'm Dr. Karen Scott, President of the Foundation, and pleased to welcome you this afternoon. Just a little bit on our agenda for today, and I will go over some logistics very quickly, and then turn to our main presentation, which will be provided by our grantees and research team at Rutgers University, Jim Lloyd and Peter Treitler, focusing on the background on the opioid crisis and an overview of Medicaid policies in New Jersey, and then on their initial analysis of Medicaid data in New Jersey, what they're learning in terms of impact on outcomes and access to care. This project is part of the Foundation's program on access to treatment for vulnerable populations, and is one of our initial sets of grants that were awarded just about a year ago. Following the Rutgers presentation, we will have commentary from Steve Tunney in New Jersey Medicaid, Ashley Harrell from Virginia Medicaid, and Dr. Doug Olson, who's at the Center for Medicare and Medicaid Services at CMS in Baltimore. We will follow all the presentations with leaving about 15 minutes for question and answer, and look forward to your input and your questions at that time. I do want to thank my Senior Program Officer, Dr. Ken Schatzkis, for doing a lot of the work on putting together today's presentation and webinar program. In terms of logistics, as always, our webinars are recorded, and following the session, you can find them and access them through our website, forefdn.org. We also will make the presentation slides available for download on our website. During the webinar, please use the Q&A found at the bottom of your screen to enter your questions, and note that you can also use functions in the Q&A box to upvote questions that you particularly would like us to get to during the Q&A session as time permits. We will provide additional resources on our website related to the webinar, including following up on questions we don't get to during the session. I will note and thank our Rutgers team that one of the resources that will be available on our website will be a full document of the chart book on their Medicaid analysis. So please plan to visit our website for more of those resources. If there are any resources that you would like to share with this audience and with us, please send them to us at our info@forefdn.org. And finally, there will be a brief survey immediately following the webinar. Please stick around for a few seconds and fill that out and provide us with feedback so that we can continue to develop our webinar series. Just very briefly about the foundation, we were founded late in 2018 as a private national grant-making foundation focused on supporting solutions to the opioid crisis. We focus on convening and supporting partners to advance patient-centered, evidence-based solutions to address the opioid crisis, and very much have a focus on patient-centeredness, and work that spans across professional education, payer and provider strategies, policy initiatives, and public awareness. I will add, in addition to that, our work is very much focused on reaching underserved, vulnerable populations and contributing to addressing health equity. And our work is really developing across three complementary activities: the grant making, of course, at our core as a foundation, but also convenings, and these webinars are are one example of that, as well as developing a range of resources and opportunities for thought leadership. So again, really encouraged and hope that you and the audience will visit our website to learn more about all three of these areas of activity for us. And now I'm very pleased to introduce our lead presenters for today. Jim Lloyd is Research Specialist at the Center for Health Services Research at Rutgers, State University of New Jersey, and Peter Treitler, Research Specialist at the Institute for Health, Healthcare Policy, and Aging Research, also at Rutgers State University of New Jersey. Jim, I'm going to turn it over to you.
Thank you so much. Next slide, please. So the first thing I'd like to do is thank the FORE Foundation for supporting not only the research that we've done and that we're going to have an opportunity to talk about today, but also for this opportunity to disseminate the early trends that we've seen and for the commentators to weigh in on it as well. We really appreciate it as researchers. Secondly, I'd like to thank the rest of the team at the Center for Health Services Research. We're really a whole team of people that do this work, and I just happen to be the one talking about it today. Next slide. So really, as so many states have over the last several years, New Jersey has been hit hard by the opioid crisis. As of 2018, New Jersey ranked 8th in the nation in opioid overdose deaths, and 0.7% of the population meets the diagnostic criteria for opioid use disorder. Additionally, which has had such a huge impact in the state, the supply of drugs itself is becoming more and more dangerous. Fentanyl and other synthetic opioids are surging into the state, which are really, exacerbating the impact of the crisis on the people who are experiencing it. Next slide. So the impact of the opioid epidemic can be seen in some of these statistics that we have on Medicaid beneficiaries. So from 2014 to 2019, you see the overdose risk for Medicaid beneficiaries more than tripled, primarily as a result of increased heroin use and synthetic opioids within the state. The crisis has also impacted racial health disparities, with rates for such overdose increasing much faster among Black beneficiaries compared to white and Hispanic beneficiaries. And then the people directly impacted by the crisis also have lots of co-occurring conditions along with opioid use disorder. Alcohol use disorder, depression, hepatitis C. It's a very vulnerable population that is being impacted by what's going on. And so it just, highlights how critical policy responses to this have to be. Next slide. So here are some graphs we have from an early paper illustrating some of the mechanisms behind the crisis in New Jersey and really why the impact has been so devastating. If you look at the top one, it's fentanyl penetration, which is defined as the percentage of suspected heroin seizures containing fentanyl. And that data is from the New Jersey State Police Drug Monitoring Initiative. And you can see it's virtually nothing in 2015. And by the fourth quarter of 2019, 80% of suspected heroin seizures have fentanyl in them. That's 4/5. And looking back at the increase in overdose deaths, you can then kind of compare that to the beneficiaries with opioid prescriptions down at the bottom, which is the percent of New Jersey Medicaid beneficiaries prescribed an opioid, and that's actually dropped substantially from the first quarter of 2015 to the fourth quarter of 2019. So the Medicaid agency itself and the providers who are operating within it are not necessarily giving out more opioids as a percentage of Medicaid beneficiaries, but what is out there is so much more dangerous because of these synthetic opioids that's having a tremendous impact on people with OUD. Next slide. So New Jersey, over the course of this time period, really enacted a large-scale state policy response. There was legislation, there was coordination with federal offices, all kinds of funding for various programs. It really kind of, spanned the whole policymaking apparatus of the state. And what we're looking at here is New Jersey Family Care, which is the New Jersey Medicaid agency, their series of policy responses, which were quite robust. And we're going to go through some of them right now. So they enacted something called the matrix model, for medication-assisted therapy, which sought to integrate various MOUD providers in the state, including establishing centers of excellence, which are leading providers charged with developing and disseminating best practices, premier providers, which is a term for clinical sites such as FQHCs, CCBHCs, and OTPs that can provide physical and counseling services together for individuals with OUD. And then the office-based addiction treatment providers, which is an attempt to get more addiction treatment into primary care, where the care hopefully will be kind of closer to the patient and a bit more integrated with other services that they need. Additionally, New Jersey eliminated prior authorization for MAT. It was first implemented in April 2019, and then it was updated again in April 20. They're consistently engaged in this, and it's really an effort to try to get medication-assisted therapy out into the patients as much as possible. There were also a number of coverage and reimbursement changes. There was increased reimbursement across the continuum of care for all the services that individuals with opioid use disorder need. There was increased reimbursement for peer support services, and support for a larger peer support program there. And then enhanced reimbursement for residential facilities within the state that were providing medication-assisted therapy. And then in addition to those kind of three large policy buckets, if you will, there were a host of other things. OORP, which is a program connecting people who present in the ED after overdose with care for their OUD and connections to addiction medicine and various other services that are available to them. The state also provided trainings for providers on best practices in the field. And they even provided a direct financial incentive for providers to get X-waivered, so then they could prescribe buprenorphine to their patients. Next slide, please. So here's a bit of detail on the office-based addiction treatment program that New Jersey put in place. As I mentioned, it is designed to enhance access and improve utilization, kind of address those common challenges that really kind of all those policies taken as a whole sought to address, which is a lack of reimbursement for addiction medicine, a lack of experience and knowledge in treating OUD among providers, and the opportunity to gain that knowledge and experience, and then help for the patients to be able to overcome the barriers to receiving treatment in many different ways. So to be an OBAT provider, we have in this box here, you have to be data waivered, you have to promote integrated care, you have to affiliate with the larger kind of matrix organization, and then you have to offer patient navigation. And that, kind of links a lot of the services together and hopefully connects the treatment that patients are receiving within the office for their addiction medicine, or rather for their OUD, the addiction medicine services, with other services out in the community, and other ways to support them in their recovery. And then alongside this, there are service enhancements. There are additional things that providers could bill. OBAT intake, follow-up is ratcheted up to the 100% of the Medicare rate, and then additional kind of direct billing for OBAT navigators and OBAT navigator follow-ups. Next slide. The other, this is another one of the discrete policy decisions that were made, was the elimination of prior authorization. In April 2019, no prior authorization was allowed for medications for treatment of opioid or alcohol use disorders, but safety edits and formulary preferences may be utilized. After getting feedback from providers and discussing with various stakeholders, Medicaid revised it again in April 2020. So only safety edits defined by NJFC, which is New Jersey Family Care, which is Medicaid, can be applied, just to help streamline the process even more for providers. And it requires MCOs to provide coverage for all generic MAT medications, regardless of dosage form. So, this is kind of engagement of the Medicaid agency with the provider community, and shows how they were kind of continuing to make sure that the policies that they enacted were addressing the needs for which they were originally brought about. Next slide, please. So within this context that I just described, we at the Center for Health Services Research were able to begin our work with these three aims. The first is our quantitative analysis of NJ Medicaid claims data, with which we can see the evolution of MOUD utilization across time, and eventually be able to examine the health outcomes of individuals who received these services. And since our analysis will cover 2020 before we're done, we have a chance to look at the epidemiology of the COVID-19 pandemic and how that impacted individuals with opioid use disorder, and how that impacted the delivery of opioid use disorder treatment to individuals who needed it. There was just, tremendous changes, of course, across the entire healthcare system. And we really have an opportunity to be able to dig in to look not only in sort of how COVID maybe, clinically or medically impacted people with OUD, but the ways in which the changes sparked by COVID-19 impacted the ways in which patients received the treatment, can also provide us with a lot of opportunities to look and see how those policy changes may have impacted that, to better inform policy decisions that are going to be made in the future. The second aim is to collect the experiences of stakeholders across the state, including state officials, representatives from health plans, primary care providers, other addiction medicine providers, and really any other relevant people to help inform our understanding of those policy developments. We've been interviewing a lot of various folks from around the state as part of our mixed methods analysis. And not only will those interviews help create a more detailed picture of what's going on, but they will also provide much more detailed context for what we're seeing in the quantitative work in AIM 1. So the two really kind of come together. It's not, there's no two separate things. It's all really integrated and built upon each other. Finally, we're implementing a dissemination program, of which this webinar is a part, that will continue those relationships with the key stakeholders in New Jersey and elsewhere, in the hope that our research can inform evidence-based decision-making going forward. Policymakers, when they're making these decisions, have to do so with good understanding of what's actually happening, what policies worked, what policies worked less. And it'll also, through this dissemination, keep us informed as to where we can be of most use for those folks going forward, because they're going to need more good, reliable evidence on which to base practice and policy. And we hope that we can help establish some of that evidence. Next slide. So to talk about some of the early trends of what we've seen in MOUD during this period, I'm going to turn to my colleague, research specialist, Peter Treitler. Peter?
Thanks, Jim. Okay, so I'm now going to walk through some of the key findings from a chart book that we put together, which shows trends in MOUD utilization, initiation, and retention from 2016 through 2019 in New Jersey Medicaid. And FORE is going to be sharing this chart book on their website as well. So if anybody wants to download it after the presentation and look further into some of the things that we're presenting today, that'll be available after the webinar. Next slide, please. So the chart book that's going to be on the FORE website and I'm going to discuss today focuses on trends in MOUD utilization from 2016 to 2019. And this is during a period where a lot of these Medicaid policies were being initiated, those that Jim discussed, and which are still being expanded today. And so we used Medicaid claims data to look at kind of baseline trends during this period, slightly before a lot of these policies were implemented and then during the early phase of implementation. And so this gives us kind of a baseline for looking at the impact of the policies, but it also helps us identify ways that things have improved over the last few years and shows us where we might focus future efforts. Next slide. So before getting into the slides on MOUD utilization, I just wanted to highlight this one graph here, which, as Jim talked about earlier, there's a lot of comorbidity in the Medicaid population with opioid use disorder. So just highlighting a few of the comorbid medical and psychiatric conditions. This figure compares people with OUD to the Medicaid population overall, and just shows how frequently these comorbid conditions occur, especially serious mental illness, which is people with OUD, 43% of those with OUD have a serious mental illness diagnosis in the same year, compared to just 13% in the overall Medicaid population. And so these kind of just show the importance of integrating care, and some of they kind of justify some of the policies that New Jersey's pursued that have really tried to bring MOUD into the primary care setting and general healthcare settings. Next slide. So on this slide, we show for overall MOUD on the left side there, as well as different types of medication, trends in the percentage of Medicaid beneficiaries with opioid use disorder who utilized medication for opioid use disorder in the same year. And so you can see here that the trends are going in the right direction. For any medication, the percentage of beneficiaries who used any medication increased from 39 to 49% from 2016 to 2019. And that increase was sharpest for buprenorphine and naltrexone. So for buprenorphine went from 16% to 22%. And it was a little bit slower for methadone, although it did increase, which isn't altogether surprising because of the difficulty of expanding capacity for methadone. Next slide. Another thing we highlight in our chart book is racial and ethnic disparities across different measures of MOUD utilization. And so this chart is simply looking at, it's comparing across race and ethnicity the percentage of beneficiaries who have OUD who used MOUD at any point in 2019. And you can see there's quite a disparity, which has been shown to be the case in many states, particularly a large disparity between white and Black beneficiaries. So for any MOUD, 58% of white beneficiaries with OUD used MOUD in the same year, compared to just 35% of Black beneficiaries. And that disparity is especially pronounced when it comes to buprenorphine, where almost twice as many white beneficiaries used the medication compared to Black beneficiaries. Next slide. Another metric that we looked at is initiation of MOUD after key events, or events that we determined would be likely to lead to MOUD initiation or indicate the need for medication. And so the first of these is a new opioid use disorder diagnosis, which we defined as an OUD diagnosis where the beneficiary didn't have a diagnosis of OUD in the prior 60 days or any medication for opioid use disorder. And so for these individuals, you can see here that the rates have remained pretty low, but they are moving in the right direction. And each year, the percentage of people who initiate MOUD has increased. And so for within 180 days of the new diagnosis, in 2019, about 15% initiated MOUD. Next slide. And so this is a similar chart, but this focuses on MOUD initiation after medically treated overdose instead of a new diagnosis. And similarly, you see here that the trend has increased and more people are starting MOUD after a medically treated overdose than before. But these rates do still remain relatively low. But I do want to point out that the actual rates of MOUD use after overdose are actually higher than this because these represent new initiations. So these are people who didn't have any MOUD in the 60 days prior and also no prior overdose. But the important thing to take away here is that it is increasing, yet remains relatively low. Next slide. So the last kind of metric that I'll focus on is retention in MOUD. And so this slide shows the percentage of beneficiaries on each type of medication who are retained for at least 180 days from 2016 to 2019. And consistent with what some of the other literature has shown, retention is highest for methadone. And so about 63% of people beginning a new episode of care with methadone are retained at least 180 days. And it's lowest for oral naltrexone. And kind of in the middle there is buprenorphine. And so we found that about 41% of New Jersey Medicaid beneficiaries who started a new episode of care were retained for at least 180 days. Next slide. Similarly, we also see a disparity, a racial and ethnic disparity in retention for MOUD. So among white beneficiaries on any MOUD, about 49% were retained for at least 180 days compared to about 41% for other races and ethnicities. Next slide. So just tying some of our findings to some of the other recent literature. This figure here, it's from an article by Robin Williams, which highlights the importance of long-term retention in buprenorphine. And so it shows how outcomes after buprenorphine discontinuation improve over time with longer episodes of care. So the outcomes that were considered here were inpatient services, emergency services, overdose, and opioid prescription. And what they did is compared post-discontinuation outcomes of 4 cohorts of beneficiaries who were retained at least 180 days. So in the orange bars there, those are people who were retained 6 to 9 months. And then the green bars represent longer periods of retention. And you can see that compared to the patients who were retained 6 to 9 months, the patients retained 15 to 18 months have lower odds of most of these outcomes with the exception of overdose. Which really shows the importance of coming up with policy and practice solutions that retain people in care, because initiating people in care, while it's very important, it will only get you part of the way. It's important to retain people long term. Next slide. And then also related to our discussion earlier, where we highlighted the high degree of comorbidity among people with opioid use disorder. This figure is from a recent study by Kelly Anderson, published in JAMA Network Open. And it shows that the quality of preventive and chronic illness care is somewhat lower among people with opioid use disorder compared to matched controls that did not have opioid use disorder. And so they looked at some standardized measures of care quality shown on the x-axis there, breast cancer screening, adherence to statin therapy, mental health follow-ups, and so on. And individuals with opioid use disorder fared worse compared to matched controls without opioid use disorder on all these metrics. And so these results kind of together with what we found in New Jersey, Medicaid data show that there's remaining gaps in comprehensive care for people with opioid use disorder, including attention to preventative care and chronic illness care. And so they kind of call attention to the need for integrating care within general medical settings, which is something that New Jersey is trying to accomplish and that we're studying now through our analysis of these policies. Okay, next slide. So just to kind of wrap up the presentation of the chart book, comorbid medical, psychiatric, and substance use disorders are common among people with opioid use disorder. And there's a need for integrated care initiatives to engage and retain high-risk people in MOUD treatment while addressing the substantial burden of co-occurring conditions that complicates their disease course. Our findings show that MOUD utilization and retention have improved over time, but there's still quite a ways to go. And then we also found, which has been shown in other states as well, that racial and ethnic disparities persist And so our future work is going to examine the impacts of New Jersey Medicaid policies on these outcomes, with the hope that that can inform policy in other states and nationally. Next slide. So I've just listed here a couple of discussion prompts because the next part of the webinar is going to include commentary from some Medicaid officials. And so these are just some things to keep in mind. Of course, we'd appreciate if you would comment on some of the findings that were presented, but these are some other things that I think kind of some questions that flow from the data we presented. So what can Medicaid programs do to increase engagement, improve treatment outcomes, and encourage more primary care providers to offer MOUD? And related to that, what are some of the remaining barriers to primary care MOUD, and what are the ways that Medicaid policies can address them? What types of policies should be implemented to respond to the high degree of comorbidity that we see in the population with overdoses, including the role of bundled payment models, such as opioid health homes? And importantly, how can we address disparities in MOUD and ensure that future policy efforts don't exacerbate those disparities? So with that, I'll turn it back to you, Karen, for the discussion. Thank you.
Peter, thank you so much. And thanks to you and Jim for a really terrific presentation and for sharing your the new data analysis with us. Again, as a reminder, on our website will be the full chart book of the analysis that Peter and Jim and their team have done on the Medicaid data for the time period 2016 to 2019. So please plan to go to our website to see more of that terrific work. I'm really very pleased now to more formally welcome our three guests to provide commentary on the presentation we've just heard and bring their perspective to this work. Steve Tunney is Chief of Behavioral Health and Customer Service for the New Jersey Division of Medical Assistance and Health Services. Ashley Harrell is Senior Program Advisor in the Division of Behavioral Health for Virginia Department of Medical Assistance Services. And Doug Olson is Chief Medical Officer for Medicaid and CHIP at the Centers for Medicare and Medicaid Services. So I'm going to turn it right over to Steve and invite him to start off on the commentary.
Okay, thank you. I wanted to start off by thanking FORE and Rutgers for assisting us in providing this research. It's been more than helpful with us in developing our program. The more research we have, the better footing we feel we're on. When we have a statistic like our overdose deaths have tripled, more than 3 times, is a little bit concerning, but those kind of statistics still help us and support us in getting the assistance we need to get programs up off the ground. In New Jersey, we're lucky we have a very supportive governor and commissioner, and we've been able to launch a lot of different programs. But this data is more than helpful. The overdose risk that's increasing with co-occurring alcohol and non-opioid drug disorders that was identified, hepatitis C, all areas that we've suspected and that we've begun to work on. But again, it's good to have definite numbers that can show that this is going to help contribute to saving lives. So our policy response so far, based on the data that I've seen in this presentation, has pretty much been on point. We've been focusing on alcohol and opioids, and our biggest thing has been removing barriers, starting with prior authorization, but we've removed many more. In New Jersey, we're lucky the 2 centers of excellence that we put in for the OBAP program have served as centers of excellence for all opioid treatment and have been a great source of communication with our provider networks and physicians out in the community. And they've been more than willing to identify different barriers that we've been able to slowly chip away at and reduce, and hopefully one day will be completely eliminated. So as stated in April of 2019, we started by eliminating prior authorization programs and medications, but we allowed the safety edits. Soon found out that the safety edits were still blocking a lot of our services from being provided. So then we made that update to that to say that made them more soft edits, so that we weren't compromising anyone's safety, but that the providers were given a chance that if given the information, we could still provide the medications. That's been very effective. Um, we've moved a lot more towards peer support services. We've expanded it with direct peers in our behavioral health clinics, as well as the OOT program, which was identified, which is essentially a peer-based program that is basically charged with just getting people engaged in treatment. They don't do much follow-up. Their role is to get the person right after they've been reversed, while they realize the severity of what happened and try and get them into a treatment program. We required MAT to be offered in our residential treatment centers based on data that we found. The residential treatment centers were pretty much all forced abstinence programs, and our governor made it mandatory that they at least offer MAT. And to support that, we did offer pay for performance reimbursement to the residential facilities. So if they can get their individuals started on MAT, then when they leave the program, we can sustain them and hopefully keep them safe. We've done something similar along the lines with our jail population. Our jails, not associated at all with Medicaid, just another great partner in this battle, have started providing MAT for individuals who are in jail, so that when they walk out the door and they're released, they're not in that precarious situation right away. It gives us time to get them connected with different programs, and hopefully will reduce the burden on our emergency rooms where these individuals were going to try and seek treatment. The last thing that was mentioned that I thought also was very good was our provider and waiver trainings. We trained over 1,000 people through our COEs and money that we got through our Division of Mental Health. But not all of those providers are directly providing buprenorphine, but I think it helped expand the knowledge that there's other programs out there, made physicians more aware of what the treatment options are. We've heard from more than one physician that when they went through medical school, their substance abuse training was approximately 15 minutes. So we felt that that was very important, and that's been a good avenue for us in getting patients into treatment, whether or not the physician is actually one of our OBAP providers or not. So looking at the medication OUD treatment initiation and retention, right now in New Jersey, that's probably our next biggest target. This data is going to go a long way in guiding our efforts. We've already heard from providers in the community that are looking to expand 24-hour access. I know on the grid it was 30 days, 60 days, 90 days, and we're looking to get people started on, within 24 hours if possible. So we have doctors out there that are taking advantage of telehealth and other connections from emergency rooms where they're seeing these patients as quickly as possible to get them started. So I'm hoping that our next round of numbers will show significant improvement as we're working hard to try and decrease that time that it takes to initiate that MAT treatment. Improving integration of care through OBAT, that was our #1 reason for initiating the OBAT program. We ran into some unexpected issues. The idea was that if the patient was already going to that doctor doctor would treat them for the substance abuse the same way they would treat them for CHF or cellulitis. But doctors were very hesitant to start posting themselves, I would say, as an OBAT provider for fear that they were going to have more clients coming to them, and they did not want to be substance use providers. They just wanted to be the family docs. So we have a little bit of work to go on there, and we'll rely on our centers of excellence to work with the physician practices to try and get past that. Because we do recognize integration of care is one of the keys, and it would help with, as what was noted, the chronic care treatment and screening for individuals. If they're there seeing their doctor routinely for substance use, then they would be there to be treated for diabetes or pneumonia or anything else that's going on with them. We've identified areas in need of network development. This is an area that I spoke with Rutgers, if they could do this in future. investigative studies so that we could see how the different areas of the state stand up. I know around our 2 centers of excellence, there's a lot of participation from providers, but they don't physically reach the entire state. And I'm just interested in seeing what that kind of data would show us and whether or not we have a need for additional centers of excellence. The research identified areas that we can address, such as alcohol and depression. We've been working with our current mental health clinics that provide substance use and or mental health. They're separated currently in New Jersey. Right now, our Department of Health and Licensing is working on revising their regulations to try and reduce barriers so that these clinics can provide the co-occurring treatment for both the mental health and the substance use. That's going to be a major game changer, I think, if we can get that through so that we don't have any additional licensing type barriers. The effect of peers is just starting right now. We just opened up that program. COVID kind of stalled our peer program a little bit because of the requirements that they had to have face-to-face hours to count towards their certification. But we're hoping as we come out of COVID that we'll get that back up and going. The opioid overdose recovery program that was mentioned is something that we anticipate right now. That's a program that's funded by our Division of Mental Health. We're just beginning to fund it through Medicaid. With additional funding, we're hoping that we'll be able to expand it so that every emergency room can offer this. So if someone comes in, was reversed chemically because of an overdose, that's when we want to get them started on treatment. We recognize that they're not always ready to accept that. So the OOT program allows us to pay peers up to 8 weeks to try and engage those clients with repeated outreach. The program feedback from providers that was mentioned, stakeholders, I think this is something New Jersey has excelled at. We still meet with our COEs and our stakeholders. Pharmacies, we include our managed care plans since they're the ones paying for the medications in our state. And we're listening right now to hospital systems, trying those hospital systems that own practices throughout the state to try and expand them into the OBAT practice. We're seeing a lot of our doctors that we tried to get into OBAT that has gone in a little bit of a different direction than we expected. We have psychiatrists, and we have pain docs, and then we have the family docs, but we've had a lot of emergency room physicians that have stepped out and 1 or 2 days a week are running these clinics. So we'll take advantage of any doctor that we can get that's willing to prescribe and treat these patients. So that's been a big help because all of our emergency rooms have been putting their patients out without any kind of, I shouldn't say that, without any kind of follow-up, but they didn't have that treatment. They would give them the medication. Now we're trying to connect them with treatment that's out into the community. So if we have physicians that are associated with the hospitals, we're hoping that they'll make those referrals. So the person has some place to go and continue that treatment.
Steve, thank you so much. I'm gonna just want to make sure we have time for all our commentary and Q&A. So I think we'll come back to, there's some questions for you on New Jersey's practices. So we'll come back to you in our Q&A. And let me turn it over to Ashley.
Thank you, Karen. And it's just hearing Peter and Jim and Steve talk about New Jersey's experience. I have to say, from a close state, it's reassuring to know that there's some similar efforts that states are doing to address the addiction epidemic. So I'm going to focus on one of the key benefits that Virginia implemented in 2017 with our transformation of our substance use disorder benefit was our preferred office-based opioid treatment model, or OBOT. And again, as Steve said this, we wouldn't be able to have made these changes without the support from the governor and the General Assembly. And so this was one effort that had full bipartisan support for Medicaid to be able to provide these services. So our preferred OBOT is our opioid health home in Virginia. We implemented this in 2017. Similar to New Jersey's efforts, our goal was no barrier access to medications for treatment of opiate use disorder and targeting our primary care settings. So they would have the prescriber as well as a co-located behavioral health provider. So we wanted those services under one roof that would be less burdensome for an individual to navigate getting this evidence-based care. With the preferred OBOT, Virginia implemented our first care coordination payment model within a primary care setting. And this care coordination was $243 per month per Medicaid member. And the role of this care coordinator is to help facilitate the team meetings between the behavioral health provider, the prescriber, the other team members within that model, and also to help patients navigate the care that they need, also to meet other social determinants of health. So similar to New Jersey, we also wanted to build this network. So not only do we have care coordination as a reimbursable new service, but we also increased rates for prescribers for starting buprenorphine, as well as increase the rates for the behavioral health services. Other things that we did, similar to New Jersey, was move the prior authorization for our preferred products for medications for opiate use disorder. And so in Virginia, that's the buprenorphine sublingual, Suboxone film, Sublocade, and Vivitrol. We also removed barriers that providers that might be serving, providing medical services or behavioral health services in addition to the addiction care to be allow them to be able to provide those services on the same day by the same provider for the same member. We also allowed for our preferred OBOTs to be able to provide services for members that might be in other ASAM, American Society of Addiction Medicine, levels of care to support that assessment and referral or providing the medications for opiate use disorder. So I'm happy to say when we implemented this in April of 2017, we had 38 sites in the Commonwealth. And as of today, we have 170 sites throughout Virginia. And the goal is to have a high-touch evidence-based care for the treatment of opiate use disorder. So when someone starts treatment, we do require weekly visits with either the prescriber or the behavioral health clinician, and then that can transition to monthly minimum requirements. However, with these efforts, Virginia, as well as other states, are experiencing the impact of the addiction epidemic. And in 2020, we'll have our worst year ever on record in Virginia for fatal overdoses. So we're looking at around a little over 41% increase in overdose fatalities in 2020 compared to 2019. So looking at what can we do different, what can the Medicaid agency do different to help address this and leverage these 170 sites that we have for our preferred OBOTs. So some thing that we're focusing on is leveraging bridge clinics. And so this is looking at how to work with our emergency rooms to initiate or start buprenorphine for members that present with an opiate use disorder, and then transition them to a community-based OBOT clinic and doing that warm handoff. We're also looking at other transitions, as Steve mentioned, individuals that are transitioning from an institutional stay, such as a hospitalization, residential setting, or a correctional setting, to community-based care. We are also looking at leveraging peer recovery support services. We see this as a part of the evidence-based practice around addiction treatment. So promoting that within our preferred OBOT model. And then we're also, Virginia was one of 15 states that were awarded the Support Act Section 1003 grant. And so part of that initiative is looking at providing training and technical assistance to providers, targeting providers who are currently OBOTs to see how they can expand services, and also looking at providing training and technical assistance to providers to help stand up a new OBOT site. This also includes trainings specifically targeting health systems on leveraging the virtual bridge clinic model. Part of the grant activities is also looking at targeting specialty providers such as OBGYNs. And then we're also looking at expanding the OBOT model to, especially during the public health emergency, and allowance of these services being provided via telehealth, but also looking at for areas that might have lower access to broadband, is to be able to provide the OBOT model via mobile clinic and having our managed care organizations reimbursed from that. Similar to New Jersey, I was very interested to see that they were allowing the preferred products, buprenorphine, to be prescribed up to 32 milligrams. And in Virginia, we do have a limit within our Board of Medicine for 24 milligrams. So that would be interesting to look at. Do the higher dosages, does that, when we're looking at continuity of treatment within our OBOT model, would that potentially yield to longer retention and care? So I appreciate the analysis that New Jersey did, and that's something that Virginia could follow.
Great, thank you, Ashley.
So, thank you, Karen.
Okay, thank you so much. And I'll turn it over to Dr. Olson.
Thanks, Karen. And Ashley and Steve, thanks for that, for the comments on this presentation. I'll say to Peter and Jim, thank you so much. What you presented was, I mean, obviously so data rich. And, you know, with that data, it just always comes so much power to be able to inform both state and federal health policy. And so thank you so much for that. Thank you to FORE for, you know, certainly funding that. It is transformational data like that you presented today. And, you know, it really reinforces, at least for New Jersey, what we're seeing nationally, right? In terms of heroin and synthetic increases, and at the same time, a decrease of prescription opioids by prescribers. I was also very much happy that you focused on the inequities that exist, both in treatment and in terms of overdose rates. I think that while I think at this point as a health system don't have a great approach to mitigating those inequities, the data to show how present they are and the structural processes and racism that underlie them is so important. And so thank you for that. You know, you presented a lot of positive data too. Increased MOUD starts, an increased number of prescribers, increased access. So there's a lot of good stuff you presented. And what, you know, I wanted to do is just let you know that what you presented are many of the things that we're working on here at the federal level. And before I forget, during your presentation, literally at 3:21 this afternoon, in my email, came from Medicaid.gov, if any of you subscribe to that, an announcement from CMS about a improving behavioral health follow-up care learning collaborative, which addresses one of the things that I think we've heard 2 or 3 times this afternoon. And the goal of this learning collaborative is to improve access to and coordination of and follow-up care for beneficiaries who visit an emergency department or are hospitalized for a substance use condition. So for anybody at the state level or other partners on this webinar this afternoon, it sounds like the gods were listening to us, as it were. But we at the federal level are really looking at the PHE flexibilities that exist right now and the impact that may have had both positively and negatively on the treatment of substance use disorders and opioid use disorders specifically. As well, I mean, with the theme of data, we are continuing to collect that and update our annual report to Congress in terms of our substance use disorder data book, and also looking at gaps in care to behavioral health treatment, mental health, treatment during the PHE. Some of that data has already been posted, and we are continuing to look at that and refine that so we can continuously update that and post it. I'm also glad to hear that New Jersey and Virginia, I knew this already, but certainly I have taken advantage of some of the more important aspects of the Support Act, which obviously is ongoing, specifically Section 1003, which increases prescriber opportunities, as well as, just leaning into that a little bit more and setting up health homes and taking advantage of an enhanced federal match for health homes related to substance use disorders, not just for 8 quarters, but for 10 quarters. We're really looking at expanding and maintaining access for all Medicaid beneficiaries, but specifically for those with substance use disorder, and with a real eye towards equity. I can't underscore enough the number of conversations and initiatives that are happening at the federal level within HHS right now that address equity. And that is really a big focus of so many agencies, and certainly CMS. Also, there are 32 states right now that have a Section 1115 demonstration authority for treatment of people with substance use disorders at the state level. And so the collection of data and ongoing meta-analysis of those so that we can eventually figure out what are some preferred or best practices and then spread those is an ongoing effort that certainly will continue for years. And there's an impressive amount of work right now in terms of the American Rescue Plan legislation and how that is going to impact state Medicaid agencies, obviously beneficiaries, with a big nod towards the substance use disorder population. I just want to wrap up and let you know some of the things that we're hearing from states and stakeholders. Because, I, before working at CMS, used to think, are they really listening? And I want you to know that we really are listening. And based on the presentation today, there are some themes that I just want to share that we're hearing from several states and from stakeholders. So the first is the importance of peer recovery support services and navigations, especially at times of transition. That message is coming through loud and clear. As well, the coverage or opportunities to potentially cover things like contingency management, especially for substances where there might be no good medication assisted treatment. The integration of care, specifically for populations where they might be at risk not only of a substance use disorder, but also things like HIV and hepatitis C. And how do institutions or states take a patient-centered approach to integrating care that really supports the delivery of services in a way that supports and maximizes the access of those services. And finally, what opportunities are there for states or again, treatment organizations to increase coverage and reimbursement for substance use disorder services at all levels. So I'm not going to say that we have answers for all of these, but I want you to know that we are hearing them and really making them part of the overall portfolio on which we might be able to provide some guidance. So thank you so much for the presentation, and I will turn it back over to Karen.
Thank you so much. A perfect wrap up. And it's nice that you're getting to hear many of the things that we're hearing as we talk with our grantees around the country as well. So nice that that's getting amplified and some good areas for us to work on. We have some terrific questions and I'm going to turn right to those. Steve Tunney, I don't know if you were able to get our message, but if you could check your volume. We do have some New Jersey focused questions, but we need to see if we can get your volume up so that that we can more easily hear your responses.
I will get as close as I can. Is that better?
That's a little better. Yeah. Thank you. I'm gonna start this one off then with Jim and then have Steve add to it. Does New Jersey Medicaid require mental health therapy as part of MOUD treatment? My state does not require counseling as part of MOUD. if this is not required in New Jersey, do you see any difference in retention for those receiving and not receiving the counseling therapy? So Jim, maybe you could start off on that. And
yeah, I can start off
Yeah.
with respect to what we've seen or not seen. I don't think we've quite looked at the question of retention for those receiving and not receiving mental health therapy, but because we haven't really gotten down to a lot of the outcomes after these policies have been put into place. But we are definitely very aware that so much of this policy was designed to integrate the various areas of treatment that are relevant for individuals with OUD, and the integration of mental health and physical health and addiction medicine is something that our center has really looked at in a lot of different areas. So we will be looking at that to the extent that we can with the data that we have. For the policy question, I just want to make sure Steve Tunney has a chance to answer because he's right there close to it.
So if you're saying mental health services, that we do not require any mental health treatment to go with the MAT. We do require counseling in different programs, such as the opioid treatment programs. With other programs, it's optional. In the OBAT, we follow ASAM guidelines where the individual has choice. If they want to go for it, we encourage it, but we don't mandate it.
thank you. Yes, John, they meant referring to counseling as part of that. The question about using the data for setting policy, and so maybe I will ask Ashley to lead off on this one, Ashley, and then Doug. Does having this data create any opportunities for integrating some value-based payment strategies? And if so, what would you focus on for metrics? Ashley?
Hi, Karen. That's a great question, and we are exploring this. We are currently working to develop metrics with our external quality review organization, and looking at things like the preferred OBOT, cascade of care models, like for individuals that are on medications for opioid use disorder, as well as individuals identified with hepatitis C and HIV. And so I think our focus this year is to continue to build out those metrics, and then probably looking more at working with our managed care contracts to do performance incentive programs, looking at maybe enhanced payments. So it's kind of an alternative payment methodology, but we're just not there yet with a value-based purchasing model.
Okay, but certainly a lot of work in progress towards those goals. Doug, what about at the federal level, or what you're seeing from other states?
We are seeing, Ashley, to your point, we certainly are seeing some states lean into the space and try to develop some, sort of incentives for people to, or for states and providers to try to enroll people in treatment and then keep them engaged. And, there's not a great metric that we have across all states to sort of measure continued engagement in treatment and therapy, as we saw today was done in New Jersey. But that is one that there's a lot of interest in. And I should also say that, there's a section of the Support Act, which is optional for CMMI, to create a model that has the potential to look at this. And so, so there certainly might be interest in that. I'm not suggesting that there are any conversations about it right now, but it's a possibility as well. But I think that in as much as we can really develop a system that is patient-centric, there's definitely interest in that.
Great, thank you. Peter, I'll turn to you. With a question about the data on race ethnicity. Can you comment on your sense of how good that data was in the Medicaid database you were using, and was there a lot of missing data?
Sure. Yeah, we do have. I saw another related question about the distribution of race and ethnicity in the overall Medicaid population. And that information is in the chart book that'll be on the FORE website. There's a comparison there showing the race ethnicity of the full Medicaid population compared to those with OUD. And as far as missing data, we created a category, 4 categories for race ethnicity: Black, white, Hispanic, and then the 4th is other/unknown. So we pulled them together, and that's 15% of the overall Medicaid population. And I'm not 100% sure because I haven't looked at the data recently, but I think a relatively small proportion of that 15% is unknown. So at the very most, it's 15% unknown, but I'm sure it's a lot less than that.
Yeah. So you're pretty confident in what you have.
Yeah.
Great. A question, Jim, maybe I'll ask you to start this one off. What do we know about billing for peer supports? Is that specifically reflected in the set of New Jersey Medicaid policies, and any insight into how effective, if there is direct billing paying for the peer supports, how effective that's been?
Sure. Yeah, it's a great question, and I have a very clear and probably unsatisfying answer. We don't have the data for the peer support billing yet because a lot of it really kicked in 2019, and as we get farther along with the 2020 data, we'll be able to see it. So it's just a matter of kind of the data lagging to us, but we are very excited about figuring out how effective this policy was. It's that integration of care question that kind of came up throughout the presentations. And we will be answering it as soon as we can, but we just don't have it on our servers quite yet.
Okay, great. So for future discussions, definitely an area we're very interested in as well. Steve, there's a question about a couple related to New Jersey policies. Does New Jersey offer mobile opioid treatment units operating in any part of the state? And any, if so, any data or about the impact of those units?
Yeah, we definitely offer mobile opioid treatment. This is something that's done through our Division of Mental Health and Addiction Services. So I'm not an expert on it. I know that there's a licensing limit so that they're essentially going into the same areas that they would cover under their license. So it doesn't allow you to go into those remote parts of the state like most people would think. But it has been used. It was one of the tools that they used to go into the jails and provide opioid treatment in the jail. So it is alive and well and throughout the state.
Great. So perhaps another area for as we look dig deeper into the data in terms of a delivery mode. Also, Steve, if you could talk about the specific policy lever, Steve, and then perhaps Jim as well, specific policy lever New Jersey is using to require MOUD in residential facilities. Is there a licensure requirement? And have all of these facilities begun to offer MOUD, or is it still in transition? Perhaps Steve, if you'd like to start. Jim.
Sure. So it was done through a governor's executive order. The biggest barrier that had to be undone was the licensing. So they put out waivers that would allow the LTRs to allow individuals to leave. They can either go out and get methadone, or they could get the buprenorphine in the LTR. There is actually 2 of those programs that are licensed to provide methadone, which is a little strange, but that was probably the biggest thing that we had to get past, and they put out that waiver. Once they could provide the service with the financial incentive for them to do it, we've seen good results.
All right. Jim, anything to add on that?
No, I mean, Steve, I think described how it's rolling out. That's another thing we're going to be looking at too as data come in.
Right. Try to get a couple more in. So comment early on, Peter, in your, Jim, in your slides that was raised by seeing the data and looking at how dramatically the fentanyl contamination rose in the drug supply back in 2019. And while we sort of, I think, associate the rises in the overdose mortality through the pandemic and the impact of fentanyl, obviously, through 2020, this seems to suggest that these trends were already underway. Just wondering if that's, that's what your interpretation or any assessment of that data is. And Jim, I think that was one of the slides you presented.
Yeah, it was. Yeah, I mean, I think that is the correct conclusion to draw. The effects of the pandemic on overdoses, were not in that data set that produced that graph. I think we're going to learn a lot about that as, we examine everything. We and other researchers examine everything that's going on. In terms of why I think fentanyl has saturated New Jersey, I wouldn't hazard a guess as to why.
I can just add a little bit to that. New Jersey was one of the states where fentanyl penetrated the drug supply earliest. I believe it was among the states that had one of the early surges in fentanyl. And I think, from my understanding, a lot of it has to do with the distribution networks that were in place, as well as the demand for heroin and things like that. So it was able to, penetrate the drug supply a little more quickly here. But it's a really interesting and complicated relationship between fentanyl and opioid overdose mortality, because fentanyl continues to actually, if we extend that chart past 2019, the percentage of seized heroin with fentanyl in it continues to increase above 80%. And I can't remember what it is right now, but it's so high, and there's actually a growing proportion of heroin seizures that don't contain any heroin at all, and they're exclusively fentanyl or an analog. But we've seen a leveling off in New Jersey, somewhat of a leveling off of opioid overdoses, even as fentanyl continues to spread. Whereas early on, they were very closely correlated. Now they've kind of, overdoses haven't increased at the same rate that fentanyl spread has. Whereas in other states, I think a lot of other states are now for the first time seeing these huge increases in fentanyl penetration. And so that's why overdoses are increasing drastically there.
Thank you, Peter. Right. Very interesting. We'll try to squeeze one more in and focus on the younger populations. And Ashley, maybe I'll ask if there's a specific work you'd like to highlight that's really focused on integrating services for youth under 18 or for young adults between 18 and 25 to look at the transitions and gaps in their care.
Thank you, Karen. Part of this, Virginia is preparing to implement some changes to our behavioral health system. So I think a lot of these services that we'll be implementing on July 1st of this year are targeted to adolescent care. So I believe Virginia will have a stronger focus on substance use disorder impact and adolescence within these services.
Great, thank you.
Sure.
So, great. We are right at 4:15. So we've come to the close of the webinar. Certainly have some other terrific questions, and we will follow up and post a Q&A document along with the webinar, other webinar resources. Again, particularly the brand new chart book from Rutgers, where you can find the data discussed today, as well as additional data points and charts. I want to thank all of our presenters, Jim, Peter, Steve, Ashley, Doug, for really terrific hour and a quarter. Thank my team at FORE for producing our program, and thank all of you for joining us this afternoon. Please stay tuned and look out for announcements for our next webinar. Thank you all. Have a good afternoon.